So can we predict and prevent systemic lupus erythematosus? This is the presentation overview. The first question that we have in front of us when we think about the early lupus and diagnosis of early lupus is really, when does lupus begin? We know that before the onset of clinical manifestation, patients who will have lupus develop autoantibodies. Clearly shown in this slide, where you can see that indeed this is the time of the first manifestation of lupus. Patients have antibodies, and these antibodies increase in number and titers right at the time of the onset of clinical manifestations. However, even if there are antibodies and clinical manifestations, we also know that before a diagnosis of lupus is made, there might be a period of time in which patients have clinical manifestations, antibodies, but they do not have a full-blown disease. And this period may last as long as 5 years. Data in the literature tell us that at the beginning of the disease, about 50% of patients have only one ACR criteria. And indeed, as I told you, the time to develop the 4 criteria, the 4 classical criteria, may be as long as 5 years. Arthritis and photosensitivity being the most frequent manifestations. But the other point is that not all patients in the gray zone will develop lupus, and some will maintain a very simplified clinical and serological profile. The literature data, here you can see some data coming from our clinic, show and tell us that about 70% of patients in the gray zone will stay there. So it's very important and crucial to separate those patients with a mild disease from those patients who will progress to systemic lupus. So which are the predictive factors for lupus development? In clinical practice, what do we use to understand which are the patients at higher risk of developing a more severe disease, lupus? Is genetic of importance? Certainly we will have information from genetics, but up to now we have to say that although susceptibility genes have been identified, these account for a small part of the risk of disease, and other environmental factors have their role. So we cannot go to the lab and ask whether the patient in the gray zone has a genetic predisposition to become a patient with a full-blown lupus up to date. So the clinical part, as doctors, we are used to see clinical manifestations. Are there clinical manifestations that can help us in understanding which patients are at higher risk? These are data from the literature telling us that there are clinical manifestations, and particularly it looks like fever, which is a non-infectious fever, and it's probably an inflammatory fever, might be of importance. But what is very important comes again to our attention is the role of antibodies. As I've shown you before, in patients with lupus, the immune system produces a large amount of antibodies, and patients who will have lupus not only have one antibody, they have many of them. So it's the large number of antibodies that are being developed that should raise a suspicion of future of a full-blown disease. Recently, this observation has been confirmed by the analysis of 85 patients with lupus prior to the diagnosis, showing that these patients have new autoantibodies and have a mean of 3 antibody specificities at diagnosis. But this data tells us another thing, that patients who will develop lupus in the gray zone, they have inflammation and they have an increased level of many mediators of inflammation, which in the future will characterize lupus. So maybe over the next years, we will be able to go to the lab and ask the lab not only the autoantibody profiling of the patient, but also the assessment of inflammatory cytokines. And this could be, again, a red flag telling us the patient is developing. As you can see here, in fact, there is a difference in these aspects between patients with lupus and patients with incomplete lupus and healthy controls, showing that in patients who will not have lupus, there are less autoantibody specificities, there are lower titers of antibodies, and there is a lower release level. But the other important point, as we want to predict lupus, but we also want to diagnose the disease as early as possible, is which are the clinical manifestations that patients with lupus have more commonly at disease onset. Literature helps as in telling that usually at disease onset we can see more often malar rash, arthritis, or hematological manifestation, while, for example, neurological manifestations are not common. And as far as less common non-criteria symptoms, again, we might find patients complaining of inflammatory arthralgias, fever, Raynaud's phenomenon, and even non-hemolytic anemia. So the clinical picture tells us and raises a suspicion for some patients that they might develop systemic lupus and puts attention in the follow-up. So the question we started with is whether it's possible to prevent lupus. And I have to say that at present it's very difficult to give an answer to this question because not knowing who will really have lupus with certainty is difficult to run trials. But there are some things that we may want to do and are not at risk for side effects for the patient. One thing that is important is the integration with vitamin D, which we know has an immunomodulatory effect on top of the bone protection effect. And it has been shown that in patients with undifferentiated diseases who progressed into lupus and other diseases, vitamin D has lower levels. So it might be useful to be sure that we take vitamin D and we integrate vitamin D not only for bone health, but also for its immunomodulatory effects. And the other very important point is that we always hear our doctors saying we have to take hydroxychloroquine for lupus because it's good, because it reduces damage, but some literature data tell us that treatment with hydroxychloroquine might be associated with lower evolution to lupus from the gray zone and is associated with lower expression of type 1 interferon-inducible genes, the ones that we have seen are increased in those patients who have lupus, even in the gray zone. So it might be another reason of being adherent to this treatment, which actually may control the occurrence or reduce the risk of having severe disease in the future. So what we can conclude with. We can conclude that we do not have specific markers to diagnose or to predict lupus, but we have information from the clinic and from the lab, which we use to define which persons might be at higher risk of having a severe disease. As far as prevention is concerned, future studies probably will tell us some useful information, but so far, at least what we know is that we have to stay strict with some treatments and probably vitamin D and hydroxychloroquine. Thank you very much.